بسم الله اللهم صل على محمد وعلى آله وصحبه وسلم. My name is Muhammad Ibrahim and I'm lecturer at the University of Hargeisa. In this presentation I will talk about the ultrasound evaluation of the ectopic pregnancy, and I will discuss the definition of ectopic pregnancy, factors and figures regarding ectopic pregnancy, signs and symptoms of ectopic pregnancy, locations of ectopic pregnancy, beta HCG discriminatory level and how to use it with correlation of ultrasound. We will see spectrum of sonographic findings. We will discuss pitfalls and confusions related to the ultrasound findings of ectopic pregnancy. And finally, we will discuss the unusual locations of ectopic pregnancy. What is ectopic pregnancy? Ectopic pregnancy is any pregnancy implanted in a location other than within the endometrial cavity. Normal position of the gestational sac is the fundus or middle portion of the uterus. It has eccentric position within the endometrial cavity. Sometimes pregnancy could be in the uterus, but is still considered ectopic, like if it is in the cervix or Cesarean section scar. So here is the normal position of the gestational sac at the fundus, not within the endometrial cavity but off center of the cavity. And this will give two echogenic lines representing the decidual papillaris and decidual varietals, separated by a hypoechoic layer of fluid in the endometrial cavity. These two lines are known as a double decidual sac sign. Facts and figures. Ectopic pregnancy incidence is 20 per 1,000 pregnancies, or simply 2%. Hemorrhage from ectopic pregnancy is still the leading cause of pregnancy-related maternal death in the first trimester, and accounts for about 4 to 10% of all pregnancy-related deaths. Up to 30% of patients with an ectopic pregnancy will have repeated ectopic pregnancy, which will affect in the future the fertility. Signs and symptoms of the ectopic pregnancy. Vaginal bleeding is seen in 85% of patients with an ectopic pregnancy, lower abdominal pain in 90%, and adnexal mass in 65%. These symptoms are non-specific, even with a positive pregnancy test and amenorrhea. So whenever you see a patient with pain and bleeding, the first question is to confirm if she is pregnant or not. If she is pregnant, then you can think of ectopic pregnancy. If not, then you can think of a hemorrhagic ovarian cyst, ruptured ovarian cyst, ovarian torsion, or PID, because these can show same symptoms of ectopic pregnancy. But keep in mind that even with the positive pregnancy test and amenorrhea, 70 to 90% of patients with suspected signs and symptoms turn out to have intrauterine pregnancy. Normal intrauterine pregnancy or abnormal intrauterine pregnancy. Location of the ectopic pregnancy. Most of the ectopic pregnancies are implanted at the fallopian tube, especially in the ambulatory portion. Rare cases are implanted in the cervix, Cesarean section scar, ovaries, and in the abdomen. Risk factors of ectopic pregnancy are periodic ectopic pregnancy, PID, history of infertility, tubal surgery, intrauterine contraceptive device, endometriosis, increasing maternal age, and period Cesarean section. Techniques. There are two techniques to evaluate ectopic pregnancy: scanning transabdominally and or transvaginally. What is good with the transvaginal scan is that it has better resolution because of transvaginal transducer frequency is higher than that of the transabdominal convex transducer and position closer to the uterus, gestational sac, and pelvic organs. Also, it advances the diagnosis of early pregnancy by about 1 week over the transabdominal scan. On the other side, the transabdominal scan has better penetration, and because it has a larger field of view, it is good for large abnormalities. So it is recommended to start scanning transabdominally to have overview checkup of the pelvic organs and see if there is free fluid in the abdomen at the hepatorenal angle, Then transvaginal scan is done for detailed imaging of the pelvic organs. What should you do? In the search for ectopic pregnancy, it is recommended to focus on 3 areas: uterus, adnexia, and cul-de-sac. Uterus is scanned to determine if there is intrauterine pregnancy or not. Adnexia is scanned to look for any mass, and cul-de-sac is scanned for free fluid. What are you expecting to see in the ectopic pregnancy? Empty uterus is number 1. Empty uterus indicates absence of intrauterine pregnancy. Sometimes there might be pseudocyst as a fluid in the endometrium. Alive, extrauterine embryo found in 8 to 25% of ectopic pregnancies. Tubal ring present in 40 to 68% of ectopic pregnancies. Adnexal mass, pelvic and peritoneal free fluid. In a patient with positive pregnancy test and alarming symptoms, if you see an intrauterine pregnancy, it will exclude ectopic pregnancy, because heterotopic pregnancy is very rare. The risk to see heterotopic pregnancy is 1 in every 7,000 pregnancies in general population, and 1 in every 100 pregnancies in patients conceived with assisted reproductive technique. Therefore, intrauterine pregnancy is highly suggestive of no ectopic pregnancy. The most reliable evidence of ectopic pregnancy is to see extrauterine mass containing yolk sac and embryo with or without heartbeat. It is not the most common finding, but it has positive predictive value of 100%. Here you can see uterus. Small amount of fluid appears in the endometrium. Just to the right side in the adnexia, you can see mass containing yolk sac and embryo. Color Doppler here for the same patient shows heartbeat. Again, here you can see uterus is empty, no fluid in the endometrial cavity. In the left adnexia, we can see embryo with crown length of 20 millimeters. The second evidence of ectopic pregnancy is to see what is known as a Bagel Sign, which simply means gestational sac outside the uterus before it is ruptured or before yolk sac and embryo is developed. Bagel Sign is a donut-looking like lesion of tubal ring with thick and echogenic wall. It might show blood flow around the wall, giving ring-fire appearance. It is said that it has positive predictive value of 95%. This is tubal ring outside the uterus and ovary. At the left adnexia, it has thick and echogenic wall, no yolk sac or embryo in it. This indicates definitely ectopic pregnancy. Another case showing Bagel Sign. This time wall is thicker, round-shaped lesion like a donut. Make sure it is separate from the ovary. With positive pregnancy test, this is ectopic pregnancy for sure. The most common finding indicating ectopic pregnancy is heterogeneous mass at the adnexia outside the ovary. It's called blob sign and represents mostly hematoma and clots in the tube. It has positive predictive value of 92%. This is the ovary, less echogenic than the adjacent mass and demonstrated ovarian follicles. Here we can see well-defined heterogeneous mass outside the ovary, which is a relatively homogeneous, likely due to blood clot around the ectopic sac within the fallopian tube. Another example of blob sign, relatively homogeneous, more echogenic than the adjacent ovary, and seen separate from the ovary. Free fluid in the pelvis. In most cases, especially in the Somali setting, patient ectopic pregnancy come with ruptured tube. Although ultrasound cannot determine rupture of the tube, but it can show free fluid with clots in the pelvis. In a patient with positive pregnancy test and empty uterus, seeing echogenic fluid in the pelvis is highly suggestive of ectopic pregnancy. 15% of ectopic pregnancies show only free fluid in the pelvis, and 50 to 75% of ectopic pregnancies show free fluid along with other findings like tubal ring and adnexal mass. Also, it is important to keep in mind that non-specific free fluid might be detected with normal intrauterine pregnancy, but this normal physiological fluid is usually small in amount and not echogenic. This is empty uterus with normal endometrium. Below the uterus in the cold sac we can see free fluid with echogenic irregular objects representing clots. Another image showing free fluid in the cold sac containing echogenic debris suggestive of blood. Then let us see some pitfalls and confusion that might be faced when evaluating ectopic pregnancy. What about if you see an empty uterus in a patient with positive beta-HCG and no evidence of ectopic pregnancy sign on ultrasound? Here, quantitative analysis of beta-HCG is helpful to correlate with ultrasound. Beta-HCG is detected as early as 7 to 8 days after ovulation or pregnancy occurs. In a normal pregnancy, it doubles every 48 hours and minimum increase is 66% every 48 hours. What is beta-HCG is 1000 to 2000 milli-international units per milliliter. It's an international preparation. We are expecting to see intrauterine pregnancy using transvaginal probe. But if no intrauterine pregnancy with beta-HCG above 2000, think of ectopic pregnancy, unless there are multiple gestational pregnancy or abortion. Sometimes you might see intrauterine fluid collection with no yolk sac or embryo, and you need to decide if it is gestational sac or pseudo-gestational sac, because 10% of ectopic pregnancies are associated with pseudo-gestational sac. Here are some tips to differentiate between the two. True gestational sac has eccentric position. It is not within the endometrial cavity. It also shows double decidual sac sign, which is two echogenic lines representing decidual capsulars and decidual parietalis separated by the endometrium. Pseudo-gestational sac is an intracavitary fluid. Endometrium might be thin and irregular. Here is an schematic drawing of the true gestational sac showing layers of double decidual sac sign. And here is the ultrasound picture demonstrating two echogenic lines on a circle with 360 degrees representing decidual capsulars, and the other is surrounded but not 360 degrees representing decidua parietalis and lining endometrium between the two lines. In opposite, here is the endometrium. It is thick and irregular and fluid is in the cavity. But keep in mind that only 10% of ectopic pregnancy show pseudo-gestational sac, and only half of normal intrauterine pregnancy show double decidual sac sign. Therefore, in a woman with positive beta-HCG, non-specific fluid collection in the endometrium, most likely is a gestational sac. Another confusion is to differentiate corpus luteum from ectopic pregnancy. And the cornerstone for this is to determine whether the lesion is intra-ovarian or extra-ovarian. Corpus luteum cyst is intra-ovarian cyst showing thin or thick wall, sometimes contain echogenic debris in it. You need to make sure it is in the ovary. It is given what is now close sign. Close sign is a radiological sign of that normal parenchyma is seen extended around the mass and determining that the mass arises from the solid structure and not adjacent to it. This video clip is showing a cystic lesion within the ovary. It has thin echogenic wall with clear fluid in it. As you move slightly to the left at next year, you will see lesion with thick echogenic wall looking like a donut. It is tubal ring of ectopic pregnancy. Here's the ovary. All is here and contains the corpus luteal cyst inside the ovarian margins. In the ectopic pregnancy, the tubal ring is here. Outside the margin of the ovary, there is a hyperechoic line separating ovary and ectopic pregnancy mass. Another helpful thing is to look at the thickness of the wall. Ectopic pregnancy is thicker and more echogenic than the corpus luteal cyst because of trophoblastic tissue. Here is the corpus luteal cyst. Comparing with the ectopic pregnancy on the right side, it is thin and less echogenicity. Sometimes we need to do dynamic scan by pressing with transducer to separate tubal ring or mass from the ovary. Look at here, when you press, you will see tubal ring separating and getting away and moving separate from the ovary. However, color Doppler is not helpful to differentiate between corpus and luteal ectopic pregnancy. Both can show fire ring with high pulsatility index and end diastolic velocity. This is corpus luteal cyst and this is tubal ring containing a live embryo. Both show fire ring, although it is more apparent in the ectopic pregnancy due to the trophoblastic blood flow. But finally, it will add not much value to the diagnosis. Then let us move to unusual locations of the ectopic pregnancy. As we mentioned before, the vast majority of ectopic pregnancies are implanted in the fallopian tube. Approximately 4% of ectopic pregnancies are found out of place in more unusual locations. These unusual sites of implantation include the interstitial portion of the fallopian tube, cervix, ovary, Cesarean scar, and abdominal cavity. Interstitial ectopic pregnancy accounts for 2 to 4% of all ectopic pregnancies, and it is the most common site of unusual of ectopic pregnancies. It occurs within the interstitial portion of the fallopian tube, where fallopian tube crosses the uterine horn. It is covered by myometrium, therefore it has the potential to grow to a larger size than the typical tubal ectopic pregnancy by the time of presentation. Usually it is presented at a later gestational age between 10 to 13 weeks. Therefore the risk and severity of hemorrhage are very high. In this patient we can see absence of gestational sac in the endometrial cavity. Myometrium in both sides are equal in size. On transverse view, this is gestational sac, an extremely eccentric location and bulges beyond the superolateral serosal surface of the uterine fundus. The myometrium appears very thin over the gestational sac. These findings are highly suggestive of interstitial ectopic pregnancy. Another image showing eccentric location of gestational sac and clear separation from the endometrial cavity. Here we can see absence of myometrium at the serosal area. And this is another example of interstitial ectopic pregnancy. Look at here, there is a myometrial tissue separating the medial margin of the gestational sac from the endometrium. Peripheral lateral to the gestational sac, no visible myometrial tissue surrounding the gestational sac. Cervical ectopic pregnancy. Cervical ectopic pregnancies occur when the fertilized ovum implants directly into the wall of the cervix, below the level of the internal cervical os and above the external os. It is difficult to distinguish cervical ectopic pregnancy from miscarriage with fetal parts in the cervical os. We need to make sure that this is not abortion in progress. Here you can see empty uterus with thin endometrium and no gestational sac. At the surface you can see gestational sac, thick and echogenic wall containing yolk sac and a small embryo. And this patient comes to the emergency department with pain and bleeding. Her ultrasound shows retroverted uterus, endometrium has no decidual reaction, no gestational sac within the endometrial cavity. At the cervix, there was irregular gestational sac containing yolk sac, but no fetal ball or embryo. 2 days later, gestational sac is identified again in the cervix, but larger with yolk sac that increased in size. Still, there was no embryo or fetal ball. The site was not mobile upon manipulation by transvaginal probe, no free fluid in the cervical canal or cul-de-sac. These findings strongly suggest that this is cervical ectopic pregnancy. What about this image? Oval-shaped, flattened gestational sac with thin wall within the cervical canal. This represents abortion in progress, or sometimes it is called inevitable abortion. Mixed hyperechoic and hypoechoic containers in the endometrial cavity of the fundus represent residual reaction and hemorrhage. The patient had a complete spontaneous abortion a few hours after the scan. Therefore, if you see in the cervix well-formed sac with prominent echogenic rim and contain yolk sac and or embryo, the diagnosis is cervical ectopic pregnancy. But if you see flattened irregular sac located in the cervical canal with thick wall and contain no embryo, then the diagnosis could be abortion in progress or inevitable abortion. Ovarian ectopic pregnancy. Ovarian ectopic pregnancy occurs for 1% of all ectopic pregnancies. It is very rare and difficult to diagnose because you have to see yolk sac or embryo in the ovary, otherwise you can decide whether this is corpus luteum or tubal ring. This can be an ovarian cyst or ovarian ectopic pregnancy. The internal echo might suggest a yolk sac, but actually this corpus luteal cyst. This is an example of ovarian ectopic pregnancy. The only way to confirm is to see yolk sac and or embryo within the cystic lesion in the ovary. And color Doppler here shows cardiac motion and ring fire. Abdominal ectopic pregnancy. Abdominal ectopic pregnancy is extremely rare and accounts for less than 1% of all ectopic pregnancies. It can be primary, that results from intra-abdominal fertilization of an ovum with subsequent direct implantation of the conceptus outside the genital tract, or it can be secondary, that results from survival of ruptured tubal ovarian ectopic pregnancy, which is then implanted to the peritoneum, omentum, or abdominal organs. This is an example of abdominal ectopic pregnancy. Here is the uterus. It is empty and no gestational sac or fetus in it. Outside the uterus we can see placenta that is not attached to the myometrium, but to a posterior uterine wall from the serosa. A 16-week alive embryo is noted in the left hem pelvis. Therefore, take it as a rule. The presence of a alive, relatively large fetus outside the confines of the uterine cavity is almost certainly a sign of an abdominal ectopic pregnancy. Cesarean section scar ectopic pregnancy. Ectopic pregnancies may also implanted in the cesarean section scars at the anterior wall of the lower uterine segment. This is increased in recent years as the rate of cesarean deliveries has increased. Here is the uterus, the endometrial strap is empty, and here is the cervix, external os, and just above the internal os in eccentric position, you can see gestational sac containing yolk sac. The location of sac within the myometrium of the lower segment, and the scar tissue seen extending to the endometrial cavity are clear indicators that this is scar pregnancy. And this is a patient with 2 period cesarean deliveries. The gestational sac is low and eccentric to the uterine cavity. Careful visualization of the cervix excludes cervical ectopic pregnancy. In cervical pregnancy, the sac would be lower and down within the cervix. Finally, heterotopic pregnancy. Heterotopic pregnancy is another rare situation where there is an intrauterine and extrauterine pregnancy occurring simultaneously. This is an example of heterotopic pregnancy. Here is the uterus. At the fundus, we can see intrauterine gestational sac containing embryo. At the left adnexia, there is another embryo with ground ram length of 19.4 millimeters. This is another patient with heterotopic pregnancy. Here is the uterus containing gestational sac with yolk sac. And outside the uterus, in the right and next ear, there is another gestational sac with thick wall containing embryo. In summary, ectopic pregnancy has a variable sonographic presentation and location. Confirming the presence of intrauterine pregnancy is the best negative predictor in the patient at risk for ectopic pregnancy. Serial ultrasound examination might be required to clarify diagnosis and monitor treatment. Thank you.